Greetings one and all. I am Dr. Himanshu from Department of Anesthesia, and today I will be speaking on fluid electrolyte and acid-base balance. So fluid balance, the general concepts include intake and output. So those are the things that you will be seeing when you are assessing for fluid balance. So for output, you have to look for sensible as well as insensible losses. Sensible losses include urination, defecation, and wound drainage, whereas insensible losses include evaporation from skin, respiratory losses from lungs. So fluid compartments, as you know, 60% of the total body weight is just fluid, of which 40% is intracellular and 20% is the extracellular compartment, which includes two compartments, interstitial and intravascular. So age-related changes. So full-term newborn baby has 80% of its body weight as fluid. It is 60% in an adult male, and as we grow older, it drops to about 40%. So transport of electrolytes, passive transport systems and active transport systems. Passive transport systems include diffusion, filtration, and osmosis. Active transport system includes the pumps like the ATP and the sodium potassium pumps, which require energy expenditure. So diffusion is one of the passive transport mechanisms in which molecules move across a biological membrane from an area of higher to lower concentrations. The membrane types are permeable, semi-permeable, and impermeable. Filtration involves movement of solute and solvent across the membrane, which is caused by a hydrostatic pressure. That is, there is a driving pressure. So it occurs at the capillary level, and it is the reason of third spacing when there is right heart failure, as there is increased hydrostatic pressure, which leads to increased filtration. Osmosis is movement of solvent from an area of lower solute concentration to one of higher concentration. It occurs through semi-permeable membrane using osmotic pressure, that is water pulling pressure. Active transport system includes the various pumps. So solutes can be moved against the concentration gradient, which is also called as pumping. So it depends on the presence of ATP as it requires energy. The types of fluids, they are classified as isotonic, hypotonic, and hypertonic, which is in relation to the tonicity of the blood and plasma. So isotonic solution, there will be no fluid shift because solutions are equally concentrated. So normal saline is an example of isotonic solution, 0.9% NaCl. Hypotonic is one that has lower solute concentration. So if a cell is placed in a hypotonic solution, fluid shifts from the hypotonic solution into the cell, which leads to cell swelling. So example of hypotonic solution is half normal saline, that is 0.45% NaCl. Hypertonic is one that contains higher solute concentration. So fluid is drawn into the hypertonic solution to create a cell balance when a cell is placed in a hypertonic solution. So there is shrinkage of the cells. 5% dextrose in normal saline, that is D5 and 0.9% NaCl. It is an example of hypertonic solution. Regulatory mechanisms, we have baroreceptor reflex, volume receptors, renin-angiotensin aldosterone mechanism, and antidiuretic hormone. Baroreceptor reflex, it is a reflex which responds to the fall in arterial blood pressure. Now these receptors, they are located in the atrial walls, vena cava, aortic arch, and the carotid sinus. There is constriction of the arterioles of the afferent arterioles of the kidney, which results in retention of fluid. So body senses that there is a decreased intravascular volumes, and it tries to decrease the urine output by constricting the afferent arterioles in the kidneys. The volume receptors present in atria and great vessels, they respond to the excess fluid. So stimulation of these receptors, it generates a renal response that increases urine output because body is sensing that there is increased amount of fluid present. Renin-angiotensin aldosterone system. So renin, it is an enzyme secreted by kidneys when the arterial pressure or volume drops. It interacts with angiotensinogen to form angiotensin 1, which is a vasoconstrictor. Angiotensin 1 is converted to angiotensin 2 using angiotensin converting enzyme present in lungs. It produces vasoconstriction to elevate blood pressure, and it stimulates the adrenal cortex to secrete aldosterone. Now, aldosterone is a mineralocorticoid that controls the sodium and potassium blood levels, and it increases the chloride and bicarbonate concentrations, and it helps to increase the fluid volume. Aldosterone is regulated by negative feedback mechanism. When the extracellular fluid and sodium levels drop, there is secretion of adrenocortical hormone by the anteropituitary, which causes release of aldosterone by the adrenal cortex, and there is fluid and sodium retention. Now, antidiuretic hormone, it is also called as vasopressin. So it is released by posterior pituitary when there is need to restore intravascular fluid volume. The release is triggered by osmoreceptors in the thirst center of hypothalamus. So if there is fluid volume excess, ADH decreases. If there is deficit, ADH increases. So fluid imbalances. The common imbalances that we see are dehydration, hypovolemia, hypervolemia, water intoxication. Dehydration is loss of body fluids. There is increased concentration of solutes in the blood and a rise in serum sodium levels. So there is shift of fluid out of cells, and that leads to cell shrinkage. The individuals who are comatose, confused, bedridden at extremes of ages, they are at risk. Symptoms and signs include irritability, confusion, dizziness, weakness, extreme thirst, decreased urine output, fever, dry skin, mucous membranes, sunken eyes, poor skin turgor, tachycardia. Can be treated by fluid replacement, either oral or IV, depending on the severity of dehydration. Monitor signs and symptoms, maintain intake and output chart, IV access, do daily weight and skin and mouth care. Hypovolemia, it is the loss of isotonic fluid from the extracellular space. It can produce to shock as well. It can be caused by hemorrhage, that is excess fluid loss in form of blood loss, decreased fluid intake, or third space fluid shifting. Symptoms and signs include mental status deterioration, thirst, tachycardia, delayed capillary refill, orthostatic hypotension, urine output less than 30 ml per hour, cool pale extremities, and weight loss. Can be treated by fluid replacement, albumin replacement, blood transfusion if there is hemorrhage, dopamine to maintain BP. You can assess for fluid overload, as can happen with aggressive treatment. Hypervolemia, there is excessive fluid in the extracellular compartment as a result of fluid or sodium retention. There is excessive intake or renal failure. Occurs when compensatory mechanisms fail to restore the fluid balance. It leads to heart failure and pulmonary edema. Symptoms and signs: tachypnea, dyspnea, crackles, rapid bounding pulse, hypertension, S3 gallop, increased CVP, pulmonary artery pressure, pulmonary artery wedge pressure, increased JVP, acute weight gain, and edema. Edema is basically fluid forced into the tissues by the hydrostatic pressure. It is first seen in the dependent areas. If it is severe and generalized, we call it as anasarca. Pitting edema is a type, and pulmonary edema. So treatment is fluid and sodium restriction, diuretics, monitoring of vital signs, early intake output charting, breath sounds, monitoring of ABGs and lab values, elevate the head end of the bed, give oxygen as required, maintain IV access, skin and mouth care, and daily weight. Water intoxication. Water intoxication is when hypotonic extracellular fluid shifts into the cells to attempt to restore balance. Now there is cellular swelling. Causes include SIADH, rapid infusion of hypotonic solution, excessive tap water or nasogastric irrigation or enemas, psychogenic polydipsia. Symptoms and signs of increased ICP. Early changes include changes in level of consciousness, nausea, vomiting, muscle weakness, twitching, cramping. Late changes: bradycardia, widened pulse, seizures, coma. Treatment prevention is the best treatment. Assess the neurological status, monitor intake, output, and vital signs. Fluid restrictions, IV access, serial monitoring of serum sodium, daily weights, and seizure precautions. Moving to electrolytes. Electrolytes are the charged particles in solution. They include cations and anions, and they are integral part of metabolic and cellular processes. So they can be positively or negatively charged. Positively charged are called as cations, and they include sodium, potassium, calcium, magnesium. Negatively charged are anions, and they include chloride, bicarbonate, phosphate, and sulfate. Extracellular major cation is sodium, while intracellular major cation is potassium. Electrolyte imbalances are imbalances in the sodium, potassium, magnesium, calcium, phosphate, and chloride levels. So sodium, it is the major extracellular cation. It attracts fluid and helps preserve fluid volume. It combines with chloride and bicarbonate to help regulate acid-base balance. Normal range of serum sodium is 135 to 145 milliequivalent per liter. Sodium and water. If sodium intake suddenly increases, extracellular fluid concentration also rises. Increased sodium, serum sodium increases thirst and the release of ADH, which triggers kidneys to retain water. Aldosterone also has a function in water and sodium conservation when serum sodium levels are low. Moving to the sodium potassium pump. Now, sodium, which is abundant outside the cells, tries to get into the cells. Potassium, which is abundant inside the cells, tries to escape the cells. It is the sodium potassium pump which maintains their normal concentrations in respective compartments. It utilizes ATP and maintains the concentration. So this is the pump that prevents the cell swelling and creates the electrical charge to allow neuromuscular impulse transmission by generating RMP. Hyponatremia is serum sodium levels less than 135 milliequivalent per liter. It is deficiency in sodium relative to the amount of the body fluids. Several types include dilutional, depletional, hypovolemic, hypervolemic, isovolemic. So dilutional is when there is sodium loss but water gain. Depletional is when there is insufficient sodium intake. Hypovolemia is when the sodium loss is greater than that of the water loss. So it can be renal due to diuretic use or non-renal maybe due to vomiting. Hypervolemic, so there is water gain which is greater than the sodium gain. So there will be edema. Isovolemic, where there is normal sodium level but just too much intake. Symptoms and signs. Primarily neurologic symptoms: headache, nausea, vomiting, muscle twitching, altered mental status, stupor, seizures, coma. Hypovolemia signs and symptoms include poor skin turgor, tachycardia, decreased BP, orthostatic hypotension. Hypervolemia, there will be edema, hypertension, weight gain, bounding, tachycardia. Treatment for mild cases will be restricting the fluid intake depending on the type of hyponatremia. IV fluids are increased per oral sodium intake for hypovolemic or hyponatremia. If there is severe case, infusion of hypertonic NaCl 3% or furosemide to remove the excess fluid, and we have to monitor the patient in ICU. If there is hypernatremia, there is excess sodium relative to body water, so it is less seen than that of hyponatremia. Thirst is the body's main defense. So when hypernatremia occurs, fluid shifts outside the cells. It may be caused by water deficit or overingestion of sodium, and may also result from diabetes insipidus. Symptoms and signs. So skin will be flushed, agitated patient, low grade fever and thirst may be seen. There will be neurological symptoms and signs of hypovolemia as well. We have to basically treat the underlying disorder with gradual fluid replacement, monitor for cerebral edema, monitor serum levels, and initiate seizure precautions. Moving to potassium. Potassium is the major intracellular cation. Untreated changes in potassium levels can lead to serious neuromuscular and cardiac problems. So normal potassium levels are 3.5 to 5 milliequivalent per liter. Most potassium that we ingest is excreted by the kidneys. The other influential factors in potassium balance are sodium potassium pump, renal regulation of potassium, and pH. Sodium potassium pump, as we have established that it uses ATP to pump potassium into the cells against their concentration gradient, and it pumps sodium out of the cell, so it creates a balance. Renal regulation involves increased potassium levels, which will lead to increased losses in urine. So aldosterone secretion, it causes sodium reabsorption but potassium excretion, so it helps in maintaining balance. pH affects potassium levels as potassium and hydrogen ions are exchanged freely across the cell membrane. So if there is increased H plus ions, that is acidosis, those cells move intracellularly while potassium moves out of the cell, leading to hyperkalemia. If there is alkalosis, that is decreased hydrogen ions, intracellular hydrogen ions will move outside while the potassium in the interstitial fluid will move intracellularly. So there will be hypokalemia in the interstitial fluid. Hypokalemia is serum potassium less than 3.5 milliequivalent per liter, can be caused by GI losses, diarrhea, insufficient intake, non-potassium sparing diuretics, that is thiazide and furosemide. Signs and symptoms include skeletal muscle weakness, ECG changes, constipation, ileus, toxicity of digitalis, irregular weak pulse, orthostatic hypotension, numbness or paresthesia. Treatment: increased dietary potassium, oral potassium supplements, IV potassium replacement, change to potassium sparing diuretics like spironolactone, and monitor ECG changes. IV potassium replacement, some words of caution: never give IV potassium bolus. Always mix with a solution. The concentration should not exceed 40 to 60 milliequivalent per liter, and the rate should not exceed 10 to 20 milliequivalent per hour. Hyperkalemia, so that is serum potassium more than 5 milliequivalent per liter. It is less common than hypokalemia, caused by altered kidney function mainly, or there might be increased intake, or there will be blood transfusions or cell death, that is strong. So signs and symptoms include irritability, paresthesia, muscle weakness, ECG changes, irregular pulse, hypotension, nausea, abdominal cramps, diarrhea. Treatment: if it is mild, we will give Loop diuretics and dietary restriction for moderate will give Kexilate, which is a potassium chelating agent, and if it is severe, calcium gluconate can be given and sodium bicarbonate for acidosis. Magnesium. So magnesium, it helps produce ATP. Its role in protein synthesis and carbohydrate metabolism, and it helps in cardiovascular system function. Regulates muscle contraction. So hypomagnesemia is when magnesium level is less than 1.5 milliequivalent per liter, caused by poor dietary intake, poor GI absorption, excessive GI renal losses. So high risk patients include alcoholics, malabsorption syndrome, GI urinary disorders, sepsis, burns, wound healings, wound which need debridement. Signs and symptoms: altered level of consciousness, confusion, hallucinations. Neuromuscular symptoms like muscle weakness, cramps, increased different reflexes, tetany, and process sign. Tachycardia, hypertension, and ECG changes. Dysphagia, anorexia, nausea, vomiting. Treatment for mild is dietary replacement. For severe is IV or IM magnesium sulfate. But while giving IV or IM magnesium sulfate, calcium should be kept for its toxicity. We have to monitor for neurological and cardiac status. Magnesium sulfate infusion. So when we use, the infusion should not exceed 150 milligram per minute. Signs and symptoms for hypertension should be assessed, and serum magnesium levels should be monitored every 6 hours. Cardiac monitoring and calcium gluconate should be used as an antidote if there is overdosage. Moving to hypermagnesemia, serum magnesium levels more than 2.5 milliequivalent per liter. Renal dysfunction is the most common cause. Renal failure, Addison's disease, adrenal cortical insufficiency, and untreated diabetic ketoacidosis. So signs and symptoms include decreased neuromuscular activity, hypoactive deep tendon reflexes, generalized weakness, occasionally nausea, vomiting. We are treated by increased fluids if the renal function is normal. Root diuretics if no response to fluids. Calcium gluconate for toxicity. Mechanical ventilation in case of respiratory depression. And hemodialysis, we using magnesium-free dialysis. Calcium, 99% of the body's calcium is in the bones, 1% in serum and soft tissue, measured by the serum calcium. It works with phosphorus to form bones and teeth, role in cell membrane permeability, affects cardiac muscle contraction, and participates in blood clotting. So calcium is regulated by intake and vitamin D intake. Parathyroid hormone is one that draws calcium from the bones when the serum levels are low, and calcitonin is one that uh, inhibits the calcium loss from bones when there is high calcium levels in blood. Hypocalcemia is serum calcium less than 8.9 milligram per dl or ionized calcium level less than 4.5 milligram per dl, caused by inadequate intake, malabsorption, pancreatitis, thyroid or parathyroid surgery, loop diuretics, or low magnesium levels. Signs and symptoms include anxiety, confusion, irritability, muscle twitching, paresthesias, tetany. There could be fractures, diarrhea, diminished response to digoxin, ECG changes. Calcium gluconate can be given with cardiac monitoring for oral or IV calcium replacement. Hypercalcemia is when serum calcium is more than 10.1 milligram per dl or ionized calcium more than 5.1 milliequivalent per dl. Two major causes include cancer and hyperthyroidism. Signs and symptoms: fatigue, confusion, lethargy, coma, muscle weakness, hyporeflexia, bradycardia, which might even progress to cardiac arrest, anorexia, nausea, vomiting, decreased bowel sounds, constipation, polyuria, renal calculi, renal failure. Treatment: if asymptomatic, we have to treat the underlying cause, hydrate the patient, give loop diuretics, and steroids if required. Phosphorus, the primary anion in the intracellular fluid. It is crucial to cell membrane integrity, muscle function, neurological function, and metabolism of carbohydrates, fats, and proteins. Functions in ATP formation, phagocytosis, platelet function, and formation of bones and teeth. Hypophosphatemia is when serum phosphorus is less than 2.5 milligram per dl. It can lead to organ system failure caused by respiratory alkalosis, insulin release, malabsorption, diuretics, decay, elevated parathyroid hormone levels, extensive burns. Signs and symptoms include musculoskeletal, which could be muscle weakness, respiratory muscle weakness, osteomalacia, pathological fractures, confusion, anxiety, seizures, coma, hypertension, decreased cardiac output, hemolytic anemia, easy bruising, infection risk. Treatment for mild and moderate is dietary intervention and oral supplements. Severe include IV replacement using potassium phosphate or sodium phosphate. Hyperphosphatemia is when serum phosphorus is more than 4.5 mg per dl. It is caused by impaired kidney function, cell damage, hypoparathyroidism, respiratory acidosis, DKA, increased dietary intake. Signs and symptoms include cardiac irregularities, hyperreflexia, poor feeding, muscle weakness, polyuria. Treatment is low phosphorus diet, decrease absorption with antacids and bind phosphorus. Treat underlying cause of respiratory acidosis or decay, IV saline for severe hyperphosphatemia in patients with good kidney function. Chloride is the major extracellular anion. Sodium and chloride maintain water balance. It is secreted in the stomach as hydrochloric acid. It aids carbon dioxide transport in blood. Hypochloremia, serum chloride less than 96 milliequivalent per liter, caused by decreased intake or decreased absorption, metabolic alkalosis, loop, osmotic or other diuretics. Signs and symptoms: agitation, irritability, hyperactive deep tendon reflexes, tetany, muscle cramps, hypertonicity, shallow slow respiration, seizures, coma, arrhythmias. Treatment: treat underlying cause, oral or IV replacement in a sodium chloride or potassium chloride solution. Hyperchloremia, serum chloride levels more than 106 milliequivalent per liter. It is rarely seen alone. It is usually accompanied by other electrolyte abnormalities. It is caused by dehydration, renal failure, respiratory alkalosis, salicylate toxicity, hyperparathyroidism, hyperaldosteronism, hypernatremia. Signs and symptoms: decreased level of consciousness, too small respiration, weakness, agitation, tachycardia, dyspnea, tachypnea, hypertension, edema. Treatment includes correcting the underlying cause, restore fluid electrolyte and acid-base balance, IV Ringer's solution to correct acidosis. Moving to acid-base balance now. Balance depends upon the regulation of free hydrogen ions. The concentration of hydrogen ions is measured in pH. Arterial blood gases are the major diagnostic tool for evaluating acid-base balance. The normal pH is 7.35 to 7.45. PaCO2 is 35 to 45. HCO3, that is bicarbonate, is 20 to 26 milliequivalent per liter. Acidosis is when pH is less than 7.5. It could be due to accumulation of acids or loss of bases. Alkalosis is when pH is more than 7.45, occurs when there is accumulation of bases or loss of acids. Three systems come into play when the pH rises or falls. Chemical buffers, respiratory system, and kidneys. Chemical buffers include immediate acting, which involves combining with the offending acid or base to neutralize the harmful effects. Bicarbonate buffer, mainly responsible for buffering fluid and interstitial blood. Phosphate buffer, effective in renal tubules. A protein buffer, which includes hemoglobin. Respiratory system, so lungs regulate the levels of CO2. High carbon dioxide is seen with slower breathing as the rate of elimination of carbon dioxide is reduced. Low carbon dioxide is seen with increased respiratory rate as there is increased elimination of CO2. Its effects are temporary but twice as effective as the chemical buffers. Kidneys, they reabsorb or excrete excess acid or bases into urine, produce bicarbonate. Adjustment by the kidneys take hours to days to accomplish, but the bicarbonate levels and pH levels increase or decrease together. So arterial blood gases, they use blood from arterial puncture. Three test results that are mainly important for the acid-base balance include the pH, PaCO2, and bicarbonate. Interpreting of ABGs: step 1, check the pH. Step 2, check CO2 levels. Step 3, check bicarbonate levels. Step 4, look for compensation. And step 5, what is the PO2 and SaO2. Check the pH. So pH less than 7.35 acidosis, more than 7.45 is alkalosis. Next step, what is the CO2 level. So PaCO2, it gives information about the respiratory component of the acid base balance. If abnormal, what does the change correspond to with the change in pH? So if the pH is high, we are expecting low PaCO2. If the pH is low, we are expecting high PaCO2. Then Bicarbonate levels. Bicarbonate levels provide information regarding the metabolic aspect of acid-base balance. If the pH is high, bicarbonate is expected to be high. If the pH is low, bicarbonate is expected to be low. Then compensation. If there is a change seen in both PaCO2 and bicarbonate, then the body is trying to compensate one or the other. The compensation occurs as opposites. Then we move on to PaO2 and SaO2. So PaO2 reflects ability to pick up oxygen from lungs. SaO2 less than 95% is considered inadequate oxygenation depending on the clinical status of the patient, while low PaO2 indicates hypoxemia. Acid-base imbalances. There will be respiratory acidosis, respiratory metabolic alkalosis, metabolic acidosis, and metabolic alkalosis. Respiratory acidosis. Any compromise in breathing can result in respiratory acidosis. Hypoventilation will lead to CO2 buildup and a drop in pH. It can result from neuromuscular blockade, CNS depression, lung disease, airway obstruction, or any chest wall or muscle pathology. At-risk individuals are post-op abdominal surgery patients, those that are mechanically ventilated, those that have been given analgesics or sedative analgesics. Symptoms and signs: apprehension, restlessness, confusion, tremors, decreased deep tongue reflexes, diaphoresis, dyspnea, tachycardia, nausea, vomiting, warm plus skin. ABG results expected are if it is uncompensated, pH will be less than 7.35, PaCO2 more than 45, and normal bicarbonate. In compensated, there will be an increase in bicarbonate as well with the pH normalizing. Treatment includes correcting the underlying cause, giving bronchodilators, supplemental oxygen, treating of hyperkalemia, antibiotics if there is chest infection, chest physiotherapy to remove secretions, and removal of foreign body obstruction. Respiratory alkalosis most commonly results from hyperventilation caused by pain, salicylate poisoning, use of nicotine or aminophylline, hypermetabolic status, or acute hypoxia which overstimulates the respiratory center. Signs and symptoms include anxiety, restlessness, diaphoresis, dyspnea, esophageal hyperreflexia, paresthesia, tachycardia, and tetany. So ABG results, if it is uncompensated, pH will be high with low PaCO2 and normal bicarbonate. In compensated, bicarbonate will also decrease with normalization of pH. Treatment includes correcting the underlying disorder, oxygen therapy for hypoxemia, sedatives or anti-anxiety agents, and paper bag breathing for hyperventilation. Metabolic acidosis. It is characterized by gain of acid or loss of bicarbonate associated with ketone bodies, which could be due to diabetes mellitus, alcoholism, starvation, or hyperthyroidism. Other causes are lactic acidosis secondary to shock, heart failure, pulmonary disease, hepatic disease, seizures, strenuous exercise. Signs and symptoms: confusion, dull headache, decreased deep tongue reflexes, hyperkalemia, which might present as abdominal cramps, diarrhea, muscle weakness, ECG changes, hypotension, Kussmaul's respiration, lethargy, warm, dry skin. Uncompensated will be seen as low pH with low bicarbonate with normal PaCO2. Compensated will be seen as normalization of pH with decrease in PaCO2 as well. Treatment includes, if there is DKA, we will be giving regular insulin, IV bicarbonate to correct acidosis, fluid replacement, dialysis for drug toxicity, and antidiarrheals. Metabolic alkalosis. Metabolic alkalosis commonly associated with hypokalemia due to diuretic use, hypochloremia, hypocalcemia, also caused by excessive vomiting, nasogastric suction, Cushing's disease, kidney disease, or drugs containing baking soda. Symptoms and signs: anorexia, apathy, confusion, cyanosis, hypertension, loss of reflexes, muscle twitching, nausea, paresthesia, polyuria, vomiting, and weakness. ABG results: if uncompensated, we are expecting increased pH with increased bicarbonate but normal PaCO2. If it is compensated, PaCO2 will also rise with normalization of pH. So treatment includes IV ammonium chloride, thiazide diuretics, and nasogastric suctioning antiemetics. We have to discontinue nasogastric suctioning and thiazide diuretics. IV therapy. Now the fluids that we use commonly include two types: crystalloids and colloids. So crystalloids are volume expanders. They are of isotonic, hypotonic, and hypertonic types. So isotonic include D5.9% NaCl or Ringer's lactate. Hypotonic include 0.45% NaCl. Hypertonic include D5 in 0.9% NaCl or D5 in 0.45% NaCl. Colloids are plasma expanders, that is, they draw fluid into the bloodstream. They include albumin, plasma proteins, dextran, and histone. And the last point today is total parenteral nutrition. Total parenteral nutrition is basically highly concentrated hypertonic solution which contains all the metabolic requirements of the patient who cannot be fed enterally. That is, we cannot give oral or nasogastric feeds to this patient, so we give the entire nutrition through IV route, that is total parenteral nutrition. So it contains electrolytes, vitamins, macronutrients, amino acids, lipids, everything. Thank you.